Cervical cancer is one disease which has got a highest mortality in our country. That's about 75,000 women are dying every year. HPV DNA testing has got more specific conclusive evidence proved as a primary screening test by FDA in 2014 only. But clinical practice guidelines of US have not yet incorporated it. These two pap smear in a lifetime also are very important. One colposcopy should be a must in one of the women's lifetime. Eradication of this cancer, rather total elimination of this cancer as much as possible by 2030.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Today we are just going ahead with one of the important topic, that's cervical cancer screening. Okay. Thank you very much, the Medflix team, and I am really very excited to deal with you all, or just to share some knowledge what I have gained over my 4 decades of practice with you all, August audience, today regarding one of the very important topic which is been really making a lot of news in our mortality of Indian women, that is cervical cancer. Friends, it is cervical cancer is one disease which has got a highest mortality in our country. That's about 75,000 women are dying every year. So one third of the global incidences of the cervical cancer is in India, that is the developing country, as we say. So whatever the incidence we are getting, like 1,40,000, in that 50% of it usually they die at the end of 1 year, because if the disease is not diagnosed in time, and if it is found out only when it is in the last stage. So such a disease is one of our priority to understand, to make you people understand, and to go ahead by each shoulder and shoulder to see that every woman is protected from this disease. And it's not only women, now it is the men are also given the vaccination to prevent the cervical cancer, and of course penile cancers in men. I am Dr. Parimala Devi here. I am a consultant gynecology and more into the preventive oncology, though I am a presently robotic surgeon team 2 in 40s. Have got Guinness record in 2015, none other than the work project of cervical cancer, that is in the field of pap smear detection, and also very eager to join my little energy in the WHO, the effort that where there is a eradication of this cancer, rather total elimination of this cancer as much as possible by 2030. So I am here to join you all to understand more about this. Today, actually, I was thinking like what exactly should go on in today's talk. Even though we say cervical cancer, it has got so much of incidence, so much of mortality, and how we have to go ahead to treat it. But we can prevent this cervical cancer if you really take little effort in educating our population, educating the families, educating the women and the men, and we can prevent it. Actually, preventive the cancer, especially cervical cancer, is very easy. Then preventing or treating the disease once it is full blown, which is going to cost us so much of family and society burden, and also financial crisis in the family. So the evaluation of the screening methods, how a cervical cancer, before it starts in the pre-invasive stage, or when woman is still healthy and she doesn't have any symptoms, how are we going to evaluate this disease? How we will prevent it is the topic today. And How we used to do when I started my practice as a colposcopist and working for cervical cancer project in way back in 1998. How was it and how it is going on now? And future what we are expecting is one of the important discussion in preventing this cancer. Why are we thinking that only cervical cancer is important, even though there are so many other cancers which is troubling our human beings and also women? Especially the cancer which is having the highest incidence in our country is now breast cancer. Next comes the cervical cancer, then it is the oral cancer, intestinal cancer, and anal cancer in women. Because the what to see the reason for all these cancers is one, that is human papilloma virus, because all the the very cause for getting this cancer is one of the viruses which is called as human papilloma virus, which is more than 140 phenotypic viruses are there. So the single cause which can create lot of cancers in man and woman is this human papilloma virus. So we have to understand more about this virus. How are we going to prevent this virus getting spread for the human beings to give the cervical cancer, or parallelly it may be a penile cancer or oral cancer in any human being. India makes about 16% of the world population but has 27% of the world's total cervical cancer cases and deaths every year. That's what I was telling. If at all we have 1,32,000 annually incidence of the cervical cancer, we have nearly in India about 74,000, the half of this we have the death rate in our country. So India has got globally 27% of cervical cancer in our country. Rest of the world it is about 73%. So the very cause of this cancer is HPV. So it has got other type of cancers because of the human papilloma virus is mouth and throat. Cervix is about 35%. Penile is about 4%. Anal canal also has the same causative factor, which is about 13%. It may be male or female. And vulvar about 11% in female. Vaginal about 2% in female. So this is the 2012 statistics. Now it has become a little bit of double of what incidence we are seeing here. And throat also has increased by 45%. Cervical cancer also by about 40 to 42%. So HPV, human papilloma virus, we all are very much aware of what is called as after COVID era. Actually, the viruses knowledge has increased for our human beings and for the thinkers and for the people who wants to analyze. But in human papilloma virus like that, we have another virus called human immunodeficiency virus, isn't it? That is HIV virus. HIV virus causes what disease? That is AIDS actually. Human immunodeficiency virus, where all the immunological system will collapse and they will become the target of all types of infections. So that is a venereal origin disease. Like that, human papilloma virus is the one which is actually present in the semen of the male gender, and also it is present in the vaginal area, anal area, oral cavity of any human being, and because of that it can spread to the cervix or to the pineal organ, and it is going to give lot of cancer changes in those respective organs. So HP is linked with 91% with cervical cancer, 70% with oropharyngeal cancers, and about 63% of penile cancers are because of the human papilloma virus. Make it a clear understanding that human immunodeficiency virus is different, human papilloma virus is different. This picture I am just bringing to your notice because this is very familiar. We all true Indians who are there, brought up in this country, and even though we travel and we come back to our country, this is the common scene which we see wherever you see there is a big population. You go to a bus to travel, there is a population, there is a overflowing number, and if it's a train, it's like this. And even now, the airlines are flooded with people, market everywhere, and very recently, the Kumbh Mela, you know that what was the population? About nearly 40% of our world population was in Kumbh Mela. So it is one of the populous country. It is very difficult for anything like however we try. the medical force and also the government sometimes fall less to prevent any disease because of the vast population, and we have diverse cultures, more religions, and every religion has their own customs and traditions to follow. What applies to one state may not be applying to another state. So because of that, it is very difficult to make uniform rules and regulations in the medical fraternity also to prevent most of the diseases. So, with this general introduction, what I would say is, what does this human papilloma virus do to the cervix? Now we know that there is human papilloma virus, that is the causative agent to create the cervical cancer. First, we'll think of cervical cancer. Of course, penile cancer is entirely a different one. And how the cervical cancer incidence is affecting our country, what is the mortality? We have just had a one dialogue. Now, what does HPV human papillomavirus do to the cervix? When it is attacking the cervix, what is going to happen? A high risk persistent HPV infection that does not clear on its own. When there is a sexual transmission, when there is an intercourse, a lot of semen can be deposited in the vagina or the cervix. Some of the viruses which entered through this route may clear on their own, but some usually these cervical changes happen very slowly over a period of years, can be treated and detected early, like it may be a cervicitis or it may be just some metaplastic change, all those things. But if not detected and treated, the infection can grow and become cervical cancer. So there are several different tests. How are we going to detect that there is a HPV infection? This lady has got a HPV infection because part of the human life is actually marriage and the progeny is to be continued. That sexual contact is a very important part of the any family married couple. But when it is HPV is so easily transmitted through the semen because of the sexual contact, it is the utmost duty of the couple to see that the woman is screened, and also the man also should take adequate precautions to see that this HPV infection doesn't happen. If it happens also, it doesn't persist there. These are a few of the things they should follow. The PAP test, HPV test, HPV genotyping test, DNA based assays like BD arm clarity, Digin hybrid capture, and COBAS test. All these tests are the one like today we are going to discuss like how we used to which what we used to do in the past, what we are doing now, and what are we going to do next. A positive HPV test does not mean that woman has a cancer is the dictum. I will be explaining to you more and more about this. Let us understand the very basic of this HPV life cycle in the cervix. If a couple is married, they are having the sexual contact and they are monogamous relation. They have very good social habits. They are not having multiple sexual partners or anything. But whatever the viruses usually which are transmitted in their normal contact, the virus can enter. Now, if at all this is the cervix, like the cervix is nothing but the mouth of the uterus. So when this cervix comes in contact with the HPV virus, the virus travels slowly to the all the layers, mature squamous layer, then the squamous layer, parabasal layer, and the basal stem cells. When this normal epithelium is there, it goes to the basement, and sometimes there will be persisting virus. There are many times different type of viruses stay there, persist there, and they are going to cause the infected epithelium, especially when there is a already infection in the cervix, like there may be a cervicitis, there may be some trichomonas vaginalis infection, there may be old trauma which has caused some epithelium denuded, ectropia. In all these conditions, these viruses will persist there and they are going to cause the virus particles assemble and virus is released. So virus uses host cell, these cervical epithelium cells to replicate viral DNA. They are the oncoproteins and express virally as encoded proteins. So this is the mechanism how this persistent virus starts creating all invasive or pre-invasive cervical changes for the cancer. So HPV infects basal layer of the cervical epithelium. If we treat at this stage by knowing whatever called as pap smear, by understanding there is a HPV infection or a HPV test or by a LBC test, which I'm going to highlight later, then we can actually prevent this virus persistingly staying there and creating the changes that may take a window period of nearly about 10 years for any virus to create all these changes. It may take some good 8 to 10 years. That is a good enough time for us, pretty good time for any clinician to prevent this virus creating our cervical cancer changes. But if left untreated, if the lady doesn't come for any screening, or if the couple are not taking care of their regular health checkups, left untreated, 20% of the patients with high graded abnormalities may develop into full blown cervical cancer. So, this is the funda how HPV virus is going to attack the cervix, which is one of the commonest thing which can happen for a normal sexual life of a couple, and it's going to cause all the changes which are going towards the cervical cancer if not prevented at the right time. So prevention by screening method is very important. So human papilloma virus, as I said, almost all cases of cervical cancer are caused by HPV. This is in the nutshell I am telling. Out of every 10 teenage girls, 8 definitely will have HPV in their life actually. And about 6 will have HPV right now. If it is in the 8 in the lifetime, among the 10, 6 at least will have presently. Every 50% of the girls at this age who are sexually active will have this virus, and most HPV goes away. And though you can catch it up again because of the sexual contact again and again, HPV virus can be there. It is not only sexual contact, even through the dental treatment and through the anal canal, also these viruses can spread. So it need not be sometimes, even though the major way of transmission of human papilloma virus is sexual contact, but it can be by non-sexual contact also. It can be fomites also can causative organ for the way of spreading the HPV virus. But some HPV gives you warts also. So some of the HPV like what we call it as 31, 33, which are non-oncogenic, can cause lot of warts. Warts are the genital warts are one of the commonest thing which can happen to the man, and because of the penile warts, everything these viruses can be again transmitted to the woman, even in heterosexual cycle also, and even homozygous sexual active lesbians also. These viruses can be spread, and some HPV can give rise to cancer. They are 6, 11, 16, and 18 are very highly oncogenic. 1 in 3 women who get cervical cancer usually will die. So it is our utmost duty to make aware that we should be taking care of this HPV virus by regular screening methods. Often, most deadly cervical cancer are often referred as the silent killer and almost 100% preventable. This cancer is 100% preventable. To tell you an anecdote about nearly about 75 years, 1925 or so, the Van Hassen was the one who found a small, a dot-like thing on the cervix, and he found that it is the infection with the HPV virus on the cervix when he was doing the research, and the human papilloma virus was found as the causative agent, and it's a silent killer by spreading over the cervix as back as nearly about 75 years ago. But still, there were a lot of allegations, and the people didn't believe it. Many scientists were not agreeing. So, because of that, the HPV viruses and HPV vaccine also took time. And now it is since few years, nearly about since 2000, we can say, most of the associations and the doctor forums are going ahead agreeing that human papilloma virus is the one causative, the main causative agent for cervical cancer, and it can be prevented because we know what is the causative agent. So the power of screening, why we should do the screening? The power of screening is one which is going to prevent this actually cervical cancer. The consequences of non-screening, what happens? They will come in the late stage if you don't screen them in time. For example, a girl of about 30 years who is married for 5 years, if she doesn't come for regular pap smear or any HPV test, definitely she will be ignorant and she may develop a full blown disease after some years, and she may come. Whoever are infected with the phenotypically the 16 and 18 type of viruses. The early detection through the screening is going to prevent 90% of the diseases. That is going to give about 10,000 506 to 5,83,497 per life year saved. So this will be the money which will be saved if it is in the preventive stage, if they come to know. But if it is in the full blown disease, if it is the stage, if they come in the late stage, then it may be so much expensive, like it will be 84 lakhs, really a crores of rupees will be spent on the treatment in the form of surgery, or it may be in the form of chemotherapy, repeated hospital visits, and lot of the multi organ involvement also can cause all these things. So what I would say is, actually, so preventive thing is the one which is going to help to prevent this disease from spreading. So let us come to know about what is the screening methods recommended by different societies in different countries differ. The commonly recommended and available tests are very few. So if you just go to the details of these tests, then it can be, these are the tests like a conventional cytology, liquid based cytology, and VIA, that is Willy or visual inspection with Ligas iodine, and HPV DNA testing, and also some mRNA testing, which are very important, which are very soon going to be part of the future screening methods. So we have to understand each of these tests one by one. Let us throw some lights by going through these tests. So for who WHO has targeted the elimination of the cervical cancer by 2030. How it is going to target this elimination of the cervical cancer? What is the strategy it is using? That is, it has come with war footing to eliminate this cancer, because WHO wants to bring 90% of the girls who are adolescents should be vaccinated with HPV vaccine by 15 years of age. 70% of the women screened with an HPV test at 35 and 45 years of age, and all should be managed appropriately. Like a young lady of 35 to 45 who is in the reproductive age group should be treated when she has already got a HPV test, she should be treated and managed appropriately. And 90% of the women identified with pre-invasive lesion, already there is a lesion. It may be ascus or it may be CN1, cervical intraepithelial neoplasia 1, stage 1. That time they should be adequately treated and a follow-up should be given. And again, 30% should be the reduction in the mortality from cervical cancer from the palliative care for all, and they should have a death with dignity, the mortality. They cannot be having a very pathetic death without any care or treatment. So this is what is WHO is targeting by 2030 to bring down the mortality to 4 cases per 100,000 women. Now we have 75,000 women dying annually, 22 per 100,000 women is our incidence. So the goal is to bring 4 cases of cervical cancer per 100,000 women per years is the, a world without cervical cancer is the dream the WHO and other bigger associations are bringing. Pap smear is considered as the gold standard in cervical cancer screening. It has brought down the cervical cancer prevalence by 60% in developed countries, because there is a protocol, there is a way, like they usually follow that pipeline of cervical cancer screening every 2 years, depending on the age, and every 5 years, depending on the inheritance of cancers in the family. But those protocols are not uniform in our country, especially in the British Colposcopy Society, UK, where I did my colposcopy training in 98. It is a real, actually, very well planned organization of the screening method. So no woman will be actually deprived of screening because of the regular protocols and what they follow and the screening methods under the insurance schemes. Like that, the patient compliance is high and patient preparation is minimum in case of pap smear. One of the commonest screening method what we follow, what we are following since ages, but still the carry home rate of this pap smear usage is still 4% in our country because of many factors, of ignorance, and the government implication is not there, and because it is not free, there are so many setbacks, and still our pap smear takers beneficiaries are very less. But it's a simple, inexpensive, non-invasive, easy to perform test, quick and painless test. Minimal clinical training is adequate, so paramedicals also can conduct these pap smear tests, and it satisfies the criteria of a screening test. Useful to detect many conditions by doing a pap smear, which is one of the basic screening tests for cervical cancer. Infections can be found out, non-specific infections also can be found out, pre-malignant, malignant conditions, everything can be put under this pap smear diagnosis. Suitable for population survey also, has a good specificity of nearly about 90%, negative predictive value of about 99%. So one of the test, I don't say it is the perfect test, but one of the important tests which we have followed since uh, decades is the PAP test, PAP smear, Papinicola smear test, and it is one of the commonest tests followed in even rural places also, in the camps also. So the pap smear has been losing its popularity. Is it losing its popularity? Will it be replaced by other screening method? As I said, like, because of sometimes the low sensitivity, because the way the smear is taken, it is fixed and sent to the lab. There can be high error rate, and by the time it is transported to the cytologist, it's very difficult to read the report because the smear will be corrupted by that time. So there are many setbacks for pap smear. So of late, is it losing its popularity? Is it going to become obsolete very soon? Is one of the logic, and the thinkers say that the low sensitivity and its limitations, and sometimes the ambiguous reports, inadequate specimen, 9.7% inadequate specimen. Sometimes they give a cytologist may say the specimen is very inadequate. I cannot give any report out of this. And malignant lesions may go undetected sometimes because the smear itself is very much not properly taken. So false negative rate can be 15 to 50%. So all these factors have put sometimes pap smear, not sometimes, many a times, into a stage where it cannot be relied upon generally to give the best screening test. So the PAP test, it has been slowly replaced by or supported by another co-testing called as liquid-based cytology. This is along with PAP test can bring down the false positive rate, and there are other tests. But what is the best test we cannot say, but there are many tests which can be supportive. HPV DNA testing, VIA and VILI testing, and E6, E7, that is mRNA testing. All these things are very important, and we have to understand whether it is a good screening test, better screening test, which is best screening test. Cervical cancer screening has gone through a lot of changes in recent past. Protocol for screening, the test of screening, once again, I am just highlighting in an elaborative way. Conventional pap smear and visual inspection with acetic acid, visual inspection with Lugos iodine, and HPV DNA testing. Speculoscopy is the simple routine clinical examination, which itself some people are avoiding. They directly send for the scanning, and automated cervical screening. In these days of artificial intelligence, we have automated cervical screening techniques are also coming. Liquid based cytology and laser induced fluorescence also is one of the future tests which we may see soon, and neuromedical systems. So all these are the screening methods which some we are following, which are about to come, and which are supposed to be very soon in the future. Our next generation may come across. So the high false negativity is due to many correctable simple problems. With whatever test we have now in the hand, like pap smear, how it can be corrected, that we have to understand, instead of like just grooming over the test which we have, and simply telling that it is not possible. We should put our efforts to bring down the error rate. That is, we have to, the limitations like specimen fixing error should be reduced. Specimen should be fixed properly. It should be a thin, uniform layer of smear we should take and put over the slide. And screening error by the cytologist also is to be reduced. Sometimes there can be screening error by the cytologist, and various limiting factors like infection, bloody smear, because sometimes she will be about to menstruate or she might have just finished the menstruation. There can be a lot of blood uh, particles also seen over the smear that may prevent the smear to be read properly by the cytologist. So these causes of limitation should be taken care so we can give a better result. The sensitivity of the pap smear can be improved by training to perform a proper pap smear. We should train our paramedicals to take a proper pap smear with the spatula, how we have to turn it 360-degree, all those methods. There is a lot of education material on how to take a pap smear. So that should be taken care and you should understand it. And the solution to the problem you should find out. Repeat the smear sometimes. Sometimes you may have to repeat the smear also, and you may have to give it to the experienced cytologist for a second opinion, and also the liquid based cytology where you are going to take the specimen and totally put into the preservative, which I am going to highlight, is one which can give a supportive finding if there is a error found in the pap smear. So pap smear, papinicola smear, and then it is the liquid based cytology, which I am going to tell now. Liquid based cytology is cytology through the liquid medium. So in the pap smear, we are going to just spread it across a slide. Here it is, the full specimen is taken and it is put to the preservative which is in this container. The cells collected from service are transferred to liquid preservative instead onto a slide, that is called as liquid based cytology. It has got many advantages. It improves the adequacy and quality of the smear. It reduces the cellular debris and RBCs. I told there will be RBCs sometimes. All these things are reduced because there will be a centrifugation of the specimen. Cells are better preserved here. Infectious organisms better preserved. Reduces the false positive rate. It improves the sensitivity and the detection rate of low grade lesions. It facilitates the computer assisted screening, automated cytology also. It saves sample and can be used for HPV DNA assessment. Usually in liquid based cytology, what we do, it's a part of it is pap smear and another part is HPV DNA test also is done, so that it will give a proper base for us to opine whether that woman is having a troublesome infection or she can be followed up by a screening method. So multiple slides can be prepared for detailed evaluation. So these are all some of the advantages of liquid-based cytology, which overcomes the limitation of conventional cytology, that is pap smear. So here you can see how the sample is taken. In case of pap smear, it is spread over the slide. 80% of the collected sample can be discarded from this brush, which we take, and smear is prefixed and sent to the lab. But in the transportation, there can be lot of damage to the slide, and the missing cells, obscuring elements limit accurate diagnosis. So non-representative sample may not reflect patient's actual condition. So these are all some of the setbacks. Whereas in case of liquid-based cytology, it can be virtually 100% of collected sample is rinsed into the preparatory vial where the container preservative is there. The sample is immediately preserved and sent to the lab. So the filtration process disperses randomized cells, and the representative of thin layer of cells is clear of obscuring elements like RBCs, debris, everything. So increased opportunity to detect early signs of abnormality. This is the advantages of liquid-based cytology, and it has got a cutting edge over the conventional cytology. But of course, the cells needed to opine the report is only 5,000 here. It's about 8,000 to 1,000, 1,200, 12,000 in case of pap smear. It's just with the 5,000 cells which are centrifuged and filtered, we can come to a lot of conclusions about the disease woman is carrying. So just to give a diagrammatic representation, conventional pap smear has a sensitivity of 72%, specificity of 94%. Conventional pap smear, clumping of the cells, debris, and a lot of dirty background of RBCs, tissues, and all is seen. We can observe here. This with the liquid-based cytology, see how clear it is. as under the microscope, clean background, and how well the cells are dispersed, rendering easier to interpretation for a cytologist. Clean background, low grade abnormalities can be made out like ASCUS, that is asymmetrical cells of undetermined significance, and low grade squamous intraepithelial lesion, glandular abnormalities. These atypical cells of undetermined significance is ASCUS, where very few cells will be abnormal. These are all the abnormalities which can be very well made out by a liquid based cytology. So, pap smear and liquid based cytology are one of the two important screening methods we are using since long time. We can put it as past or present also. So, LBC liquid based cytology increases the quality of the smear, but sensitivity to detect higher grade of lesion is same as that of conventional smear. But limitations of LBC are very few. Smear patterns are altered because of randomization, abnormal cells are dispersed. Cell nuclei often take on a more vesicular delicate appearance. Epithelial cell round up and appear smaller than the conventional smear, but these are can be made out, but we get a proper report compared to conventional smear. Other than these two tests, HPV DNA testing is one which has got a lot of importance these days because HPV DNA testing has got more specific conclusive evidence proved as a primary screening test by FDA in 2014 only. But clinical practice guidelines of US have not yet incorporated it. But in India, we are already doing HPV as the primary screening test also, and HPV vaccination to prevent cancer also. So the recommended primary HPV screening algorithm is like this. Primary HPV screening, if it comes positive, then it is type 16 and 18 positive, then we are referring them to actually colposcopy. Hello, doctor. You have a follow-up consultation request on Dr. 20 followed by 7. So then if it is 12 other high risk HPV, then it is cytology. Then we have to send her for a follow-up of 12 months because it's only primary HPV screening 12 other than 16, 18. If it is negative, then the routine screening. But if it becomes 16 and 18 positive, then it is colposcopy. Of HPV DNA testing is to categorize women into two groups, negative and positive. If it is negative, prolonged interval of screening. You need not screen her for at least 5 years, we say at least 3 years. Then if it is positive, needs a close follow-up by a colposcopy also. In the positive, again, she is carrying whether low risk HPV types or high risk HPV types, we have to see. So HPV DNA test has, I am speaking from pap smear, LBC, now I am into HPV DNA test, one of the important screening method. HPV DNA test has been strongly promoted as primary screening modality in US but not in other countries. HPV DNA is recommended for women who are more than 30 years. It was before 25, now it is 30 years. The infection is more prevalent at this age. It is transitory and resolves itself. Presence of virus does not equals to presence of CAN, because just because virus is there, she has already cervical intraepithelial neoplasia. It is wrong. Positive HPV DNA is not confirmatory of developing cervical cancer. It only says that she has HPV infection, but we have to work up and find out at what status, what stage the lady is at the risk of developing cervical cancer. HPV test could lead to more unnecessary and invasive procedures, so it should not be done below the age of 30 years because sexual contact is more common in those ages. So there will be HPV virus which is present in the specimen. So it is to be done after the 30 years, and then we can repeat it as it is required. And there is of course colposcopy also to prevent the progression of the disease. Understanding the pathophysiology of HPV DNA test results is essential to appropriate management. Like HPV testing detects infection present at the time of testing. At the time of testing, how is the status it is detected? Cannot detect past infection or infection that is cleared. If there was a past infection, like how in diabetes HbA1c will give us the past sugar values, it cannot do it. Testing cannot predict the small percentage of infection which will not resolve but persist infection, the persisting viruses infection, I am telling. Testing cannot detect abnormal cell changes in the cervix. That for that we have to use colposcope. HPV DNA positive women need further testing. Always, again, if at all there is a positive, we have to do the phenotyping, we have to do the colposcopy, we have to do further testing, which I will be highlighting. So HPV DNA testing, the interval can be again once negative, another 5 years need not do. Various situations where it is recommended is follow up after, especially you have treated a pre-invasive lesion. To follow up those women, you can use this HPV test, DNA test, triage of the women with equivocal cytological report. If there is some pap smear report which is telling ascus, atypical cells of undetermined significance, and if there is something like glandular abnormalities are seen, lot of chylocytes are seen. That time you can use this HPV DNA testing and to give a proper conclusion about the health of the woman. So limitations of the test need to be understood before adopting HPV DNA testing as a screening procedure. So HPV DNA testing has got no DNA damage or DNA damage when it is progressing. If it is regressing because of the HPV infection, then it can be no actual test will be negative. So that leads to undue anxiety, unnecessarily HPV test, positive test. So presently it is cost prohibitive also. It can give rise to over treatment also. So unnecessarily you should not be doing, but the primary prevention of cervical cancer, HPV test has got its own role. 86.7% of the positive women did not develop cervical cancer or CN even though they were HPV positive. But our motto is to see that whether this lady has got any carcinogenic type of phenotypic viruses like 16, 18, 6 and 11. Those viruses, if they are there, we have to be more seriously working with colposcope and other molecular tests also. The positivity is higher in younger women because of the lifestyle and the sexual contact. So the cost is prohibitive for HPV DNA test. So because of that, there are many co-testing like HPV and PAP test are also sometimes done. And there is one test called CARE HPV or CureGen, which is yet to become more prevalent in our country, not yet available. I can say I am at least not finding with any of the laboratory. And I think Metropolis is soon going to come out with this CureGen test, low cost rapid test. This is, if this comes, it will definitely help us to find out more and more HPV infection and also early cervical cancers. So solution is there to come out with more low cost test which will give us more rapid report also. So the management protocols are defined depending on the co-testing result. Co-testing means you will be doing a HPV negative test and a pap smear negative. Both tests are done. So you can just coolly tell you that woman not to come for a screening for 5 years unless really she has some other genetic tendency or there are mother having cervical cancer, any the genetic inheritance is there with any other cancers in the family on maternal side. HPV negative and pap smear is positive, then you can go ahead with colposcopy because colposcopy will clearly rule out and we can go ahead with the biopsy. And you know that histopathology reports are the golden standard at the end to come to a proper conclusion. HPV positive and PAP negative, repeat after 12 months. HPV positive and PAP positive, then you have to do a colposcopy. So we have to combine the test, co-testing, and we have to conclusively give the report. Cervical cancer screening, co-testing, the combined testing is proposed to overcome the limitations of both PAP test and HPV DNA testing. So there is one more test which is very handy and can be used with low resource also is what I was telling is visual inspection with acetic acid. This is just done under the magnification light on a couch where you do the pelvic examination. Apply 3 to 5% of the acetic acid after cleaning the cervical discharge which is there with a normal saline. And then you can apply acetic acid for a minute and observe the cervix. The moderate specificity results in resource being spent and unnecessary treatment of women who are free of precancerous lesion in a single visit approach. There is no conclusive evidence regarding the health or the cost implications of overtreatment, particularly in areas with high prevalence. It is likely to be less accurate among post-menopausal women. These are the limitations actually, but At least in the low resource setting, you can see the whiteness of the cervix and some metaplastic changes with the naked eye itself, and we can make them at least to take up the other test, and you can ask them to go ahead with the colposcopy test in the future. But the strength of VIA are many. It's a simple, easy to learn approach that is minimally reliant upon infrastructure. I told in a PSC, in a general hospital, in a camp, you can do visual inspection with acetic acid application and really come to a lot of conclusions. See and treat are the concepts which are going on from the WHO, and it has been held up to in a low resource settings to go ahead with this test instead of doing nothing because there are no cytologists available, there is no LBC kit available because of the cost. So this VIA will come handy, and it can be help us to low startup and sustaining the cost. And many types of healthcare providers also can perform the procedure, and test results are available immediately. Requires only one visit. May be possible to integrate VIA screening into primary healthcare services. So VIA has got its own advantages in the low resource setting. So the low cost test has been recommended for resource poor and economically weak countries by WHO. It has been recommended. You can see here how the after application of the acetic acid it is looking, the especially the transformation zone on the cervix is looking so white as a metaplastic change, or it may be CN1 also. A biopsy is definitely recommended here. And after application of the Lugos iodine, you can see properly this mahogany brown color is a normal area. This may be just an inflammation, and there can be an nephrotic cyst. All these things can be worked up, and we can come to a conclusion whether any biopsy is required by means of this VIA test. Visual inspection with acetic acid, visual inspection with Lugos iodine are some of the screening methods which we are doing. And subjective depends on the performance experience, of course. For that, you have to be a experienced clinician, a gynecologist who has done many of the VAA and VILI actually, and has low specificity and rate of unnecessary interventions may increase. Suddenly, patient will be coming under the anxiety that there is something going on in her service, even though it may be benign, and she may get into anxiety and she may go for more hysterectomies also. Cannot distinguish infections. Accuracy is low in postmenopausal women because the transformation zone which is there is inward. It is drawn inside because of the atrophy of the cervix. Sometimes the results are not very satisfying. I would like to just share this video here where the next test, which is, I will not call it as a screening test, but the colposcopy, when there is VIA is not giving the conclusive evidence. HPV test also is very much ambiguous. Then we come to the one of the best and the very important test is colposcopy. It's an outpatient procedure where cervix is seen under the higher magnification. Clinical gold standard test, I can say. As a colposcopist of about 25 years experience from 1997 or 98, I have been doing a lot of colposcopy wherever there's a doubt from the pap smear or from the LBC test or the HPV test. So indications for the colposcopy are many. It may be just the unhealthy cervix. When you look at the speculum examination itself, can be an indication for colposcopy. And also, if there is a pap smear, something called as ascus, and in the LBC, if there is a CN1, something suspected, then also we can is the indication for this one colposcopy. And after taking the acetic acid application, these are some of the steps. Lugos iodine are used here. You can see when it is applied, the cervix will show a lot of changes by application. It may be aceto whitening, punctation, mosaicism, or it may be, as I said, it may be a polyp, or it may be atypical vessels, which are significant, abnormal vessels are significant of pre-invasive lesions. So all these changes can be seen under high magnification light by using the colposcopy, and you can treat them by just by a leads biopsy where you are going to take out that abnormal area and going to give a thermoablation or the cryocardiometry. And this biopsy is the gold standard. If it comes with whatever findings, we are going to treat it under the scoring system called sweet score. So this is the very advantage of colposcopy, which is one of the, we cannot call it as a screening test, but we have to put it as one of the conclusive evidence can be given by means of colposcopy when there are some setbacks with pap smear, LBC, and also HPV DNA test, VAA, and VILI. Yet another new method which we are looking more, sometimes some of the places has got this mRNA testing, even though they are the cost is high, but they will definitely give a conclusive evidence without because for colposcopy and all you need a trained colposcopist to do the test, and we have very colposcopist actually. Only in big cities you can get colposcopist, so it is very difficult to give that service. That time this mRNA test can be of use because these are all viral oncoproteins needed for progression of the pre-malignant lesions. If these are found out well in advance by a test, then we can really treat that woman with a much vigorous and adequately. Overexpression denotes definite malignant transformation expressed as a positive or a negative. Still in a trial basis. These tests are still in trial basis. I think very soon we are going to see this test available. The molecular test detects 5 genotypes of virus, that is 16, 18, 33, 34, and 45. Serves as a more specific discriminator between transient cervical lesions and other evident cervical lesions. Useful as a triage for LSIL, low grade squamous intraepithelial lesions, and ASCUS positivity. Specificity are more than HPV DNA testing. Indicates a persistence and progression of the lesion after the treatment. Also, this test is very important. That is E6 and E7. Cervical cancer screening in Indian situation, what is happening is conventional cytology suffers a lack of specificity. LBC is limited by its cost as a primary screening method. HPV DNA testing is not cost effective as a screening method because it is sometimes commonly comes as a positive, and VAA lacks the specificity and quality control. So E6, E7 assay is still not easily available. So what best we can do is the question. W has recommended its member countries to develop an integrated cervical cancer screening into their health systems depending on the social, cultural, economic context. This will ensure a definite referral system for diagnosis, treatment, and follow. Each health system should develop its own screening protocols suitable to their country, their religion, because if it is some of the dominated religion dominated people may not like to have a pap smear, and some people usually have the ritual of undergoing circumcision by the population, male population. They have low cervical cancer incidence because the semen concentration may be not having so much of virus load. So there are so many things like we have to carry out depending on the culture and also economical context of the country. So reality about cervical cancer screening is 100% risk of cervical cancer cannot be eliminated by screening. No screening test is perfect. Everything has got its setbacks. Remember, periodic screening is necessary. Only once screening is just not possible. At least two pap smear in a lifetime also are very important. One colposcopy should be a must in one of the women's lifetime of 15 to whatever we say, like after the marriage of 3 years of marriage to her 65 years. The method of screening depends on the preference and the socio-economic status. In a country where the hand-to-mouth problem is there, we cannot ask them to go for this HPV test or colposcopy test on and often because there is so much of poverty and economical burden is there in the family because of the children education and so many social responsibilities. So cervical cancer screening has gone through a lot of changes in recent past. Protocol for screening, so it may be exfoliative cytology like conventional pap smear, liquid-based cytology. It may be automated cervical screening technique, it may be HPV testing, laser induced fluorescence, which we have now yet to see, VIA, speculoscopy, all these things have been part of the cervical screening. And cervical cancer screening, like QAGEN test, has been a low cost rapid test. We are looking for this. And the summary for bringing about effective control of cervical cancer, the National Cancer Control Program should be integrated within the existing health network. Already we have a health network like the vaccination program, the screening program. In that, we have to again implement these programs also, and with other national control programs such as AIDS and sexual transmitted diseases. A separate vertical program is neither feasible nor desirable. It's very difficult. So you have to integrate these systems also into that. It's not only the screening, it's also the vaccination. Vaccination also can prevent lot of cervical cancer, but vaccination will not come under the screening method. It is a preventive method of cervical cancer development by giving the young population of about 10 years to 26 years 2 doses of vaccine, and more than 26 years 3 doses of vaccine. That may be Gardasil or it may be Cervavac, which is available now. Both male and female population both should be actually vaccinated, and we have to prevent the cervical cancer and penile cancer by making them safeguard. So these are some of the preventive methods which the screening methods which we have used, and we are supposed to actually implement according to the situation, according to the availability of the cultural status of that country. Thank you very much for kind listening. And this is my Guinness record day, like in 2015, June 22nd, where I could really do some service by a big population of 702 in one of the rural place by doing the pap smears from morning to evening under the Guinness record team, along with help of Rotary and Parimala Hospital. And I am very thankful and very happy to share this with you all, Augusta audience. And I will be very happy to give some more clarification if there are any question. Thank you very much.
Thank you, ma'am, for that wonderful session. We do have a lot of questions coming in from our doctors, and we will be getting into that. So, ma'am,
Pardon?
I'm taking one of the earlier questions that we had.
Okay.
It is Dr. Madhav. What bottlenecks are in India for effective HPV vaccine management?
For HPV vaccination, first of all, it is the ignorance, I can say. Like people, even though like in the COVID era, the vaccination was accepted very fast and very progressively because there was a mortality in case of COVID virus and COVID era. But what happens in HPV? It is a silent killer because there can be infection, but there is no viremia, there is no fever, nothing. The virus enters the cervix or the penile organ, and very silently it starts replicating depending on the social factors, whether their immunological capacity, how it is, whether they are having any smoking history or multiple sexual partners, and their health status, like whether there is anemia, so many things. So the virus silently spreads, and after some certain stage, when it's second stage, third stage of the cervical cancer, when surgery or radiotherapy or chemotherapy is needed, they will come to know. So because of that vaccination, even though it has come, still they are not believing. And very sorry to say, there are a lot of anti-vaccine group because of the different cultures, different religions. There are some debates which are going against, but it has been proved again and again by all the research and by all the societies, by the WHO and also the American Cancer Body also has proved it that because of it is a viral protein, actually DNA protein, which is attenuated and vaccine is produced. It is no live virus or anything in this vaccine, so there cannot be any reaction or any bad long term side effects with this. It is going to give lot of high antibodies to see that the girl or the boy will fight with this HP virus when it is more increased in their body. So this point is should be taken, and of course, our political system also can be responsible because these vaccination system should be put in the national schemes, like how our polio vaccine or the other vaccines are given. Even this vaccine should be included in the school syllabus and school vaccination system. So the pediatric vaccine, how children will go and take, even for the adolescent, this vaccination should be advocated. And also women should be more and more aware, understanding they can prevent this cancer by just by vaccination by 80% is a big boon actually. Instead of simply misunderstanding and not understanding logically, they are trying to take the unnecessarily setback. And other than this, the cost, even though they are telling it's costly, it was about 4,000 or 5,000 when I started giving the vaccine in 2005 or 206. I can say nearly since 15 years, this vaccine is available actually. But now the cost has come down to 50% because of more people are taking, even though we have less number beneficiaries, but there are some people who are coming forward. The schools are going for the vaccination, mass vaccination. So because of all these things, the rates have come down. And whatever it is, the vaccination, for example, it's something 2,000 rupees for one dose. It is two doses is 4,000. I would always say, maybe I'm wrong in telling, if at all you go to a mall or to some festival or some kind of entertainment, you'll be easily spending 1.5 to 2,000 rupees. So if you can safeguard your life, your mother's life or your sister life, I'm telling this addressing to the man who is sometimes head of the family. If you can take care of your daughter's life, the health and everything, this money should be worthwhile spending and going ahead. So these are some of the, other than this, religion and cultural uh, status also will come in the way, because in some population they don't like to take any vaccines. Like in like this, there are many things which are there, we can say, as a setback.
Right, ma'am. So moving on to the next question. Dr. Kulkarni asks how to diagnose uh, cancer of cervix at the earliest.
At the earliest. That's what I said. At the earliest means if she's a girl is married, and usually immediately after the marriage we don't do. Usually after 2 to 3 years of the marriage, when she's exposed to cervical the semen because of the sexual contact, we start screening her. Once in 3 years, the Pap smear is done. But if the Pap smear starts showing some inflammation or some ascus or some kind of abnormalities, then every year it is repeated. And so instead of pap smear, if they can afford, then they can go for this liquid based cytology. So by screening her, at least by examining her in a clinical test like speculum examination, we can definitely make out is there she is at the risk of cervical any disease. I won't say directly cancer, any disease or any pre-invasive lesion before developing. They will definitely go through these pre-invasive changes that will take nearly 5 to 6 years. If this stage, if they can be diagnosed, usually we can prevent them 90% from developing cervical cancer. It's a screening, we can say. We have to screen them. We have to see them.
So next question from Dr. Nitin. What can be the differential diagnosis of cervical cancer?
Differential diagnosis, cervical cancer as such, we cannot this one, but some there is a suspected pre-invasive lesion. It may be a polyp also. It may be a punctation also. It may be some Nepothian cyst also. Cervical cancer can be types of cervical cancer. So differential diagnosis are actually inflammatory lesions, or it may be something called polyp, which is with a lot of vascularity, and also it may be because of the traumatic HPV infections, and also because of the old trauma of delivery that is infected again. All this can be differential diagnosis.
So next, Dr. Gupta asks, ma'am, what are the types of vaccines for cervical cancer and its schedule? Is there any age beyond which the vaccine cannot be administered?
Usually, pregnant ladies, we don't administer the vaccine, even though it is not a live vaccine. Still, there are some researchers, and we don't want to take any risk of giving the vaccine and baby getting affected, even though it may be very less chance. The type of vaccines are two types. We used to get bivalent vaccine and quadrivalent vaccine before. Quadrivalent means four types of viruses were attacked by the vaccine, that is 6, 11, 16, and 18. They are the pathognomonic of causing cervical cancer. But now bivalent vaccine is not available. That company has closed. But we have quadrivalent, which is more potent actually. And also we have another quadrivalent vaccine, Servavac. These are the two brands which are available. So I am right in taking the brand name also. And they are easily available in most of the places now. And usually the correct age is between 9 and 14 years, the young adolescents, which will give 90% protection. If not, 15 to 26, which will give 80% protection. This is called as catch-up age. If this age we cannot catch them and give the vaccine, then it is more than 26, it is up to 45 to 50, that is 3 doses we have to give. But after the 50 also, if they come for vaccination, nothing wrong in giving, because it will something better than nothing. It will give at least 50% protection. So these are the ways like a vaccine is given, and it itself is a big topic. We can speak for hours together. And lactation time also
Um,
it can be given. And boys are also vaccinated now. Of late we are vaccinating because penile cancers are also increasing because of the social habits. So we are vaccinating the boys also.
so, Dr. Patel asked,
Yeah,
young married lady in her 20s having coitus with her husband, can she still be vaccinated against HPV? If yes, then which vaccine is recommended?
we can vaccinate the HPV vaccination, as I said, the charger from HPV vaccination can be given because of, as we said, it's from the 9 years to 12 years or 15 years. So that is the right time, like HPV vaccination should be given. The, uh, the first coitus itself can deposit lot of viruses in her genital organs. So it is very sensible to get her the vaccination and to give her the protection. Which vaccine is, just now I told, it's two types vaccine available, quadrivalent vaccine available. One is Gardasil 4, another one is Cervavac. There is one nanovalent vaccine also available. 9 phenotypes are there in that. It's very costly. If they can afford up to 9 to 10,000, even that vaccine also has already hit the market. That is
So,
Gardasil 9.
Dr. Kumar says, are the screening tests and the vaccine freely provided by government at government hospitals?
Vaccine, I don't think, as my knowledge goes. Presently, I'm not in government hospital. I'm in a corporate now. But screening test, Pap smear is free. I don't know about LVC because I don't think government will give such a costly test so freely. Pap smear is free, supposed to be free. Everywhere it is free. It's supposed to be, but I don't know the system inside how it works. We don't know.
Another question from Dr. Kumar is, which is the best test for screening with the highest
That
sensitivity?
is, we can say it as a HPV test only. Human papilloma virus test is the best test which can be done. Actually, even though, as I said, the SCOBAS test, QIAGEN test, which are all not freely available, they are all molecular test. They are also supposed to be very good test, but not very readily available for time being. For time being, HPV test is the best. We usually do HPV test in our practice wherever they can afford. Otherwise, we do Pap smear and send.
Dr. Devra asks, what is the success rate of HPV vaccination? Also, can a woman be protected against cervical cancer simply by observing the contraceptive devices?
This is a good question. Success rate of HPV vaccination, as I told, in a young population up to 26, it's about 90% protection. Of course, the social habits also have to be good. It's not only vaccination. She have to be monogamous relationship, no smoking, and the general health like the weight and the obesity. All those things should be taken care with a good diet and all. With all that, 90% protection is there. Condom can be like a sexual hygiene. It is like safe sex. It can prevent to some extent the viruses entering, but still the condom breakage and all those things and the habits, social habits can add up, and there can be some kind of the failure of condom also. Sometimes if there is a breakage or anything, the viruses, even before the foreplay secretions of the semen also can have HPV viruses without the condom. Not a total protection, I can say, but it is helpful. It is supposed to be a safe sex way of doing the sexual act.
So, ma'am, in the interest of time, is it okay if we take two, three more questions from the audience?
Please take, please take.
So, Dr. Ravi asks, there are multiple serotypes of HPV. Will the HPV vaccine give prophylaxis against all of them?
That's what, because there are more than 140 types of this one, but few are been found to be very pathognomonic of causing cervical cancer. That's what I said, 6, 11, 16, 18, 31, 33. 52. That's why this nanovalent vaccine has come now, because these pathognomic, these 9 types of viruses have been tackled in that. That will give more protection because of the nanovalent. But to all the viruses, it may be, they may be, other viruses may be causing the genital warts actually. But oncogenic capacity is for these 4 viruses, 6, 11, and 16 and 18. They are totally taken care. So whatever accordingly I told, some 90%, 80% protection according to the age and the social habit, it can give the protection. And of course, if there is a immunodeficiency, if they are immunologically compromised, they are on steroids, and they are already having some diseases and all autoimmune diseases, that time the protection may not be so good. So it depends on the general health of the person also.
So, Dr. Hanifa says if she has condyloma, can we give Cervivax?
Cervivax is first of all not available only. Cervix, I would say Cervivac, yeah, Cervivac. Condyloma, if it is there, it can, and condyloma can be treated also by a thermoablation, cryocuttery and all have come now. We can treat it. It is not a bar for any vaccination or anything. Vaccination should be given immaterial of whatever the age, as it is said, up to 50, 55 years, because they are sexually active sometimes up till 55, 60. And they can be given unless the pregnancy in a young lady, there it is prevented. Otherwise, it can be given because it is not a live vaccine. The reactions are very nil, I can say, in my experience, from 1998 to some 2005 to now, vaccination we are giving, no reaction.
Dr. Swami asks, ma'am, is there any national action plan for HPV vaccination and prevention since vaccination itself is very costly?
That's what the national vaccination program has to be implemented now. Actually, it is not yet implemented, but FOXY, our Gynecological Society all over India, which is governing body for gynecologists, and Pediatric Society for all pediatricians, they all have joined hands, and they have come out with their own guidelines to bring the vaccination more and more into use. But government implication, like making it as a must and should, like you must be reading over the paper everywhere. In some of the states, they have started, like it's a must, vaccination is a must, but authoritatively still it is not included in our systems. So because of that, people are refusing. Now nobody will refuse the vaccination of whatever the polio and influenza, whatever vaccination usually they take. But this vaccination is still an option because it's with lot of emotions, and the girl chastity, so many things are involved. So it is cannot be forced also sometimes, but soon I think it will be included in the other protocols also.
So, doctors, taking the last 2 questions for tonight. Dr. Agarwal asks, is it advisable to give nanovalent vaccine if the female has previously been vaccinated with quadrivalent vaccine?
It is actually sometimes if once quadrivalent is given, you can give nanovalent, but we say that nanovalent is to be repeated. One quadrivalent, one nanovalent, again quadrivalent, like that we cannot mix match. If at all quadrivalent she has taken, she is taking nanovalent, of course she is able to afford, and that nanovalent will cover more phenotypic viruses. She have to repeat the full dose. If the age is more than 26, 3 doses. Below 26, 2 doses. That's what is the current understanding going on now. Of course, single dose vaccination also is going to be the practice very soon, but a lot of research and antibody titers immunogenicity is to be measured. It's still not very much approved by the WHO.
In the last question from Dr. Sharma, what percentage, I believe, sir is asking, what percentage of unmarried females can develop cervical cancer from age 30 to 55?
What percentage of unmarried female?
I believe sir is asking, can develop cervical cancer from the age of 30 to 55.
Unmarried status doesn't mean that the virus will not attack. It is not the status of the marriage or anything. It's the sexual act. Whether you are married or unmarried, if there is a sexual act, that is the main causative factor for cervical cancer. Other than I said sometimes it can spread through the dental treatment also. It can spread through the anal canal to vagina also, because of the lot of genital warts, just the skin to skin contact of the male and female, because of the foreplay or something, that also can give rise to lot of viruses entering the genital tract. But the sexual act, when it happened earlier, the sexual act, more is the cervical cancer chances are there. So because the tissues are very delicate and viruses can enter more easily, and more sexual partners, smoking, all these things can add up for the cervical cancer. Then the marital, if she is married, if she is not having a sexual contact since many years because husband is not living with her, she may not develop cervical cancer in the future. But
With that,
there are incidences what I have read. Maybe I am wrong also. I'm sorry if at all I am wrong. There are some women who were exposed to only one sexual act, became a widow, and stayed without any sexual contact. Also have developed cervical cancer very rarely, even with one contact also. So it is something like very tricky sometimes. Maybe the virulence of the virus also matters, and the genetic inheritance tendency to develop a cancer in the family is sometimes differs, the genetic tendency.
ma'am, thank you so much for taking so many questions very patiently from us.
No problem.
And with that, I'd also like to mention that there are a lot of positive comments for this session and a lot of
Because it's
appreciation.
the most happening topic now, happening problem. We can take another session again, once again, only question answer session we can make it.
Right,
Just
right.
live session where they will ask question, we'll answer. That
Yes.
is much better.
So thank you once again, ma'am, for this wonderful
Thank
session.
you.
It was
Thank you
very
very much. I really enjoyed this August gathering. Thank you.
Thank you so much, ma'am. We really hope to see you again on Netflix. Thank
Yes,
you once
thank you.
again, ma'am.
Thank you.